Assessing the severity of aortic stenosis requires a meticulous multi-window approach. Because ultrasound is angle dependent, failing to use multiple views can lead to an underestimation of the jet velocity and therefore the severity in up to 20% of patients. The following 5 views are the gold standard for a comprehensive evaluation, forming the basis of the continuity equation used to calculate the aortic valve area. The parasternal long axis view is the starting point for anatomic assessment and the first step in quantification. Evaluate the morphology, calcification, leaflet thickening and restricted motion, doming, and measure the LVOT diameter. This is done in mid-systole from the inner to inner edge of the septal endocardium to the anterior mitral leaflet, usually 0.5 to 1 cm proximal to the valve. A small error in this diameter is required in the area formula, so take multiple measurements to ensure accuracy. Some authors have recommended measurement at the annulus rather than 0.5 to 1 cm proximal to the valve. Parasternal short axis view, often called the Mercedes-Benz view, provides a cross-sectional look at the valve. The name comes from the appearance of the closed aortic valve in cross-section, though it is upside down. This is the best view to identify the number of cusps, example bicuspid versus tricuspid, and occasionally quadricuspid. In some patients with excellent image quality, you can perform 2D planimetry to manually trace the aortic valve orifice area, though Doppler method remains the primary standard. Apical 5-chamber view is the primary view for hemodynamic assessment because the ultrasound beam is usually most parallel to the flow of blood leaving the heart. Use pulsed wave Doppler to get LVOT VTI, that is velocity time integral in the left ventricular outflow tract region, and continuous wave Doppler or CW Doppler to get the aortic valve VTI. DVI, Doppler velocity index, is a crucial dimensionless ratio between the two values. Ensure the cursor is perfectly parallel to the jet. Use color Doppler first to identify the aliasing turbulent jet to guide your CW placement. Apical 3-chamber view, also known as apical long axis view, serves as an alternative or confirmatory window to the apical 5-chamber view. It provides a different angle on the LVOT and aortic valve. If the apical 5-chamber view yields a lower velocity than expected, the apical 3-chamber view may offer a better alignment with the eccentric jets often seen in calcified valves. Suprasternal notch view is frequently overlooked but is vital for picking up the highest possible velocity. This view looks down into the ascending aorta. In many patients, particularly those with a dilated aorta or an eccentric jet, the highest velocity is found here rather than the apical windows. Using a PEDOF blind probe in this position is highly recommended for accurate grading. PEDOF is an acronym derived from the term Pulsed Echo Doppler Flow Meter by the Norwegian engineers who developed it. We used to call it as a non-imaging pencil probe. You can align the probe for the best Doppler signal by keeping your eyes shut and concentrating on the Doppler sound heard in the loudspeaker of the echocardiography machine.